Welcome to the PROstep MICA Solo Procedure Guide launch event. Your host for the evening, from the Cleveland Clinic London Hospital, orthopedic surgeon, Mr. David Redfern.
Well, hello USA from London. Good evening. We're here to introduce and launch the PROstep MICA Solo Guide. And to do that, we'll have a panel of experienced MICA surgeons across the pond on the East Coast who I'd like to introduce to you now. So on our panel, we have Dr. Becky Cerrato. Hi, Becky. Peter Mangone.
Hello, David.
Hi, Peter. And Erroll Bailey. Good evening, Erroll.
How you doing?
It's lovely to see you all. It's a shame I can't be over there with you, but this is the next best thing. So we're here to discuss the new guide, which is the third generation and the evolution probably of 10 years of design work to reach this stage. We're really excited about it, and I want to tell you a little bit about the history first. So the first generation of hallux valgus percutaneously really rests with Stephen Isham in the 1970s, who developed a percutaneous Redfern osteotomy, which is a rotational osteotomy, and in experienced hands, yes, reproducible, but really quite difficult in terms of learning curve, and definitely a risk of AVN and other complications. It's not fixed. It's difficult in terms of reproducibility. I think that's the conclusion. Second generation, and we're really talking the noughties and Giannini, Bruno Magnan, all quite important players in Italy in developing this. But again, it's not fixed. It's difficult to control in the sagittal plane. Now, my journey in MIS began, 14 years ago now, and my French colleague, Joel Venois, came to work in the UK, himself recently energized at that time by meeting Mariano de Prado from Spain and being introduced to the beginnings of percutaneous surgery. And that's when we embarked on this journey to develop the MICA. And I think the real advantages are that we combine the best of open and percutaneous surgery, the minimally invasive approach, but the reproducibility of internal fixation. And the real key is that reproducibility, that confidence in outcome. And I hope that's where the PROstep MICA Solo Guide is going to take us a big step forward. So I'd now like to turn to the panel and ask them about their experience. And we're going to go to each one. First, Dr. Cerrato, and ask a little bit about your MIS journey. What's your story, Becky?
Well, David, thank you. And I think you know this because my journey in MIS really began with you and Dr. Venois and a couple of other of your colleagues who came over from Europe to Baltimore, actually, in 2009. And I had just started practice in 2008. So I was this young attending, ready to learn new ideas. And at first, it was a little frightening to look at something so radically different. But at that point, I really thought you guys were onto something, and I wanted to learn some more. So a couple years after that, I actually went over to your side of the pond and took my first GRETMIC course. And that is really where my eyes were opened to percutaneous forefoot surgery. Enough so that the following year, I was inspired enough to start an advanced arthroscopic course here in the US that I would hold annually, and even invited GRETMIC, you, Dr. Venois, to come as well. And we started putting together both an arthroscopic and percutaneous course. And we did that up until just this past year. MIFAS or GRETMIC put together their last course just this past November in Washington, DC. And so I've been an early adopter, as they call it in the US, and it's been nothing but a positive experience in my practice.
Thank you, Becky. Peter, tell us a little bit about your experience with MIS.
So thank you, David, and thanks for being here tonight, everybody. I had the good fortune of training with a very wise surgeon, James Samarco, and Jim always taught me that if you were doing the same thing that he taught me 10 years from now, that I wasn't learning. I wasn't advancing my practice. And that's really the attitude that I've always taken, not change for change's sake, but change to try to evolve and improve what I'm doing. And as you get into practice, I was about 12 to 15 years into practice and seeing results from some of the surgeries. Some of them turned out okay, but some of them not so great. And I was looking to see what better improvements I could make to my practice so that my patients could have better outcomes. And so I was fortunate with some of the work that I've done in arthroscopic work. I teamed up with Becky and her course in Baltimore, and then subsequently I met you and Joelle and was introduced to minimally invasive techniques, including the MICA technique, and really was quite taken aback by the initial x-rays. But then once I learned the rationale behind it and the experience, and then subsequently went on to do it, I've been, as Becky said, nothing but happy. My patients have been happier, the outcomes have been better. And so here I am today as we try to launch this new evolution and the next stage in the process.
Thank you, Peter. Moving on to Erroll. Erroll, you and I met, I think, 4 or was it 5 years ago now in New York?
4 or 5, yes.
Can I have your experience?
Well, first I want to say thank you and Joelle for bringing this technology to this continent. It has been a game changer. I first met you in 2018. That was my first experience with minimally invasive surgery. You were lecturing. And I had seen MIS before, but the fixation was inadequate to me. There were osteotomies with simple K-wire fixation. And I just wasn't a believer until I saw the MICA procedure. I saw you perform it. I was in a lab with you, and you taught me how to do it. I went back home to Atlanta, and then subsequently went back to Memphis and Wright Medical and asked for additional training, which I got. And since that time, my growth in MIS has been incredible. And I simply don't know what I would do without it in my practice now. So I'm very grateful for that.
Erroll, I want to come back to you, but we're going to let Peter now move to the lab and put a different hat on. He's going to take the star role in a minute. And so we'll say goodbye to you for a moment, Peter. And I want to come back to you, Erroll, because you're more recent to this, and I know you've done a lot of cases. Has your caseload changed? Has your practice changed in terms of what you do now as a result of MIS?
My entire practice, David, has changed. I'm now looking for ways to innovate and incorporate more minimally invasive techniques to my practice. It has grown 25%, and I attribute that all to minimally invasive surgery and those techniques. About every third room I go into now, there's a PROstep pamphlet on the door, and people are interested.
Yeah.
And so it has been a tremendous addition to my practice.
I think you touch on a point there, Erroll, that patients start to drive this, don't they?
They sure do.
Becky, what's your experience? What do patients say about MI surgery? What appeals to them?
Well, I think bunion surgery has a reputation of being difficult. Number one, a very painful procedure to go through, very difficult to recover from. There's very few people that come into your office and don't have a family member or a friend that tried to warn them out of doing it, but yet they're there anyway. I mean, their bunion hurts, they want this addressed. And this has almost been like, you know, the clouds have parted for patients as well. You know, when, certainly in the US, when we started discussing on forums that minimally invasive bunion surgery was an option, it absolutely was a floodgate and opening. And these are patients that they were looking for a better answer to it. And so the majority of my patients are very well informed, very well educated, they've done their homework, and they're coming in looking to see if they're a candidate for a minimally invasive approach to their bunion.
So thank you for that. I think now we're going to lay the groundwork for the guide. Erroll, perhaps you'd take us through the key elements of the MICA and set the scene as to why the guide's required.
Well, this procedure has a very high learning curve. The osteotomy of the bone itself, one can learn very quickly. However, it's the shifting of the bone the tilting into varus and the frontal plane rotation that's difficult. And at the same time, you're trying to fire a wire down the middle of a metatarsal bone, out the lateral cortex, into the head, and you want it to all be perfect in all planes, and that's extremely difficult. So what this guide is going to do is make this reproducible, less stressful, and you can do this solo.
So it's a stress buster.
Without question.
Okay, thank you for that, Erroll. So now, Becky, we've established the need for the guide. Maybe you'd take us through the key elements of the guide. Can you do that for us, please?
Sure. So the concept of the guide is to be able to, once you've created your chevron osteotomy or metatarsal osteotomy, is to introduce our guide into the osteotomy site, translate the head over in the exact position you want to put it into. So you've got controlled translation. You're going to be able to pin and hold it there, so you're not constantly trying to hold the position that you've been able to acquire. And then at this point, you're going to be able, again, in a very controlled and reproducible manner, introduce those two guide pins in a parallel fashion, both in that AP and sagittal plane, into the head where you want it. And you're going to be able to do all of these independently and not have to be doing this with your hands all at the same time or require an assistant to help you with this.
Right, exactly. So this really is a way of having an assistant there in a jig, in a guide that takes some of the stress out of the surgery, allows you to concentrate on where you want the head, and the things you should be freed to think about. Is that right?
Exactly. I think it's able to allow the surgeon to kind of focus on individual steps and not 10 of them all at the same time.
Yeah, yeah. Well, let's go now to the animation. And Becky, it's a fairly brief clip, so I just want you to take us through the key elements before we then go to Peter in the lab for a more detailed look at it.
Sure. So this is going to be a very quick animation, as David had mentioned. And so we're going to see through this animation the chevron osteotomy created using the 2x20 millimeter burr, as we're familiar with. And once the osteotomy is created, you're going to see the pusher assembly for this MICA solo guide be placed in. And I'm going to walk you very quickly through some of the steps for this. So here's the pusher assembly getting introduced, the proximal guide attached, and the trajectory guide. You can see the metatarsal head pinned, translated over how you want it. There are 3 different options in the trajectory that you're going to place your 2 guide pins. Once you've determined the trajectory that you want, and you can use this alignment guide to do that, you are then able to, at this point, and surgeons who have done this are familiar with this, you're going to pin for your 4/0 screw. You'll be able to put in this same alignment guide, the guide pin for the 3 millimeter screw, and then you have these 2 guide pins sitting there in the position you want. Your head has been translated in the position you want, and then you'll be able to drill and place the screws in the same controlled fashion that you had done before, except now you're not trying to do this all with your own 2 hands. Once both of the screws have been placed, you get your x-rays, you like your position, you like your screw placement, then you can disassemble the jig that we'll see here in a moment. And as we all appreciate, you also need to resect the spike. So surgeons can then place the screw guide over the 4/0 screw and use this jig to actually pin a trajectory that's going to place, and you can drill over this into the canal of the metatarsal protrusion, and you're going to be able to take the spike off using your burr, but now in a very controlled fashion, which I think is, for those of us who have gotten very familiar with the cut or screws, this can oftentimes be one of the more stressful steps. So we're finished with the animation, and I think at this point we're going to take it over to the lab where my colleague, Dr. Peter Mangone, is going to take us through a live demonstration. Peter?
Thank you, Becky. I appreciate it. So we're set up here in the lab. Just for frame of reference, we're going to be doing this procedure with the foot in the positions that you'll see it. In general, you might have the foot in a different position in the operating room because the patient's going to be on the bed, the leg is going to be extended out either off the table or up in the air with you rotating a C-arm around it or using a large C-arm. But just for demonstration purposes, we have it set up today so that you can see what we're doing with the guide. But recall that you will have your normal setup in the operating room. So we've discussed earlier the basic osteotomy is a short chevron type osteotomy. We can see up on the fluoro. We've already done the osteotomy here. It's a slight short chevron there, which I think is important. It helps to control some of the dorsiflexion, plantar flexion of the distal fragment as you translate it. So that's what I typically do is a short chevron type cut. So we've made that cut. We can see we're down in the area where, go ahead and take that shot there, where we've got this at the metaphyseal, diaphyseal, extracapsular area. So the first step would we would free up the osteotomy a little bit, which we did with a freer or an osteotome where we can go in and we can kind of get into the canal, kind of mobilize that osteotomy. Go ahead and take a shot there. All right, so once that osteotomy is mobilized, then we take the guide. We'll want to have it all the way out so that you can see this tine. And if we can see that well, the tine is all the way out. And so we're going to come in from the top side. It's easier to get in from the top side and get into the canal. Kind of place the tine into the canal, rotate around, and then we'll be able to verify that it's in the canal. X-ray there, please. Good. So we know that we're in the canal at this point in time. So now we'll attach the proximal aiming guide. This goes into the slot and it clicks. It'll click into position, and then once it clicks into position, then what we can do is we can start to look at our sagittal alignment. Now, as you can see, I already drew some lines on the foot where we have some of the, kind of, that's my kind of external guide to start with. But then we'll want to position and look to get a lateral view in order to make sure that we're aligned. This is where this guide is radiolucent. Just hold that there, Christopher. Radiolucent and helps us to be able to see as best we can the sagittal alignment. So take an X-ray there. And we can see where, and it's almost a goalpost type arrangement. So you can see where the head of the first metatarsal is, and you can see the guide kind of going down along the aspects of the metatarsal head. And kind of outlining the first ray. You want to start at that juncture. Now, what I will usually do is I like to take a pin, and up here at the cuneiform level, I like to put a pin just up at the cuneiform level, just underneath or inferior to the guide. And what that does is the tendency is for the foot, as you use the guide, to kind of have the guide drop down just a tiny bit. So this helps to kind of keep my hands free. I can kind of leave the guide as is. If the foot is like this, it doesn't drop down off of that alignment. It's not an aiming mechanism, but it's just a way to kind of add that little element of stability. So now that we have that in good alignment, we're going to start to engage the osteotomy just a little bit. We'll be rotating this knob right here. That starts to engage, and we'll want to kind of capture the osteotomy in the semicircle or the concavity of the guide. So we have kind of captured this in there just a little bit. If we get an X-ray there, we've see that we've started to
Peter,
shift
just
this over.
recapping.
Go ahead, say that again.
So just recapping, Peter. So far, you've engaged the guide, and you've spent a little bit of time just making sure it's in the right alignment.
Correct.
And it's snugging down onto the metatarsal nicely. Okay.
So we've got that there. Go ahead and hold that there. So we're going to continue to, I'm just going to push it just a little further. Once we've kind of engaged it just a little bit, now we can go ahead and rotate and pull the head into just a slight amount of varus. We don't want to translate it and push it into valgus. And now we're going to pin it. We're going to pin the head where we want to hold that position. So you can use, there are two different holes. You can use an inferior hole or a superior hole. We'll use the superior one here, X-ray there. And we're just going to kind of, you can see the sesamoids are rotated. I've got the head in a neutral to slight varus position. And we're going to just go ahead and put that across just to kind of hold that there, X-ray there. Okay, so that kind of is going to allow us to hold the head as we translate. Now we're going to go ahead and start translating. And while we're doing this, it accomplishes two purposes. One is we're going to translate the head laterally, X-ray there. At the same time, we're also pulling the first ray into varus. I don't know, David and Becky and Erroll, do you want to comment on the importance of pulling that first tarsometatarsal joint into a slight varus alignment while I continue to work on this for just a second? Well, go ahead, hold that there for me.
Well, yes, you tend to want to stress the TMT joint and move the base of the first metatarsal as lateral as possible when you shift your head, and that's going to reduce the likelihood of recurrence by doing that. So that's a very important step. And this guide does both. It translates the head laterally and pulls the metatarsal medially simultaneously. So this is a good thing.
X-ray there.
I call it the grandma step, Erroll, because most patients come in and they say, I've seen my grandmother's feet. I don't want mine to look like hers. And yet they're coming in with a bunion. No, it's not as bad, but kind of something tells you that it's going to get that way. So the correction shouldn't be what we see in front of us. It's the correction for her grandma's foot. So we're taking out that capacity for recurrence, aren't we? Is that right, Becky?
Yes.
Right.
And I think Pete might not have mentioned it when he was doing some of it, but you saw when he was rotating the head before he pinned it, he also was holding the hallux inverus, which any of us who do this freehand and we put our device in, we're taught to hold that toe, the hallux inverus, to prevent any angulation of the head. And I think that's a really critical point before you put the pin in, that's kind of holding the head in the position you want before you do any further translation.
Right. But before Peter goes any further, what else would you be doing at the same time, though, Becky? You'd be pushing up on the head to make sure it doesn't plant a flex. You'd be holding the elevator you're using to get the displacement. Several things.
Yes.
And here, Peter's got all the time in the day. He can think about each one of these steps whenever he wants.
Yes, and think of the amount of x-rays you're not taking anymore.
Yeah, good point.
So now the next step, we will make a little incision here to be able to place the guide, the drill guide in. Then we'll go ahead and advance the drill guide for the larger screw. X-ray there. Let's see. Go ahead, X-ray. Good, and that's where we want it, kind of right on that joint edge. We might even want to be a little bit lateral. We'll see, or a little bit medial. X-ray there. Good, so we'll be right on that edge.
What do you think of the displacement?
Well, I think it looks very good. You can see, obviously, a fairly significant displacement there. And now, one of the nice things about this, go ahead and hold that, Chris, is that we want to then take and we want to try to see, well, is this going to be the right alignment for our guide pin? So we can take this and get the overlapping view. So you'll notice X-ray here. Those pins are not overlapping. We want to overlap those pins to get a true AP of where the screw is going to go. So X-ray there. Almost.
So you're aligning you're aligning the proximal screw sheath, the guide wire sheath, with that guide wire sitting on top of the foot. Is that right, Peter?
Correct, so that we see overlapping. You can see here that I think I'm going to be a little too far lateral there, so I think we're going to go ahead and change out. This has several different options. We're going to go to a more medial position.
So to be clear, what we're not doing is putting the guide wire in, having a go, oh, it's not quite right, moving it again. And it's avoiding that fiddling around. We're aligning it without actually driving the wire into the foot yet.
Correct. Now, X-ray there. And we can see, and you can see where we actually moved that starting point a little bit medial, and then we'll once again get this aligned. X-ray. Oh, X-ray there. And again, we'll get. So we can see where that's going to be in the head, and we could actually be a little bit, if I move this just a tiny bit, we'll kind of pull that off there you go, X-ray there. And that's, again, there we go. So we should be okay with that.
You're pretty close, you're getting there, aren't you?
We're getting there, yeah. Hold on just a second. The one earlier today obviously went smoother, as usual. All right, X-ray. Let's see where this is going. That's what I like better there. So hold on, just give me a temporary pin real quick. I'm just going to put that in just for a second. We're going to grab that spot because that's a good starting spot. All right, X-ray there. Good, I like that starting spot right on that shelf. Now, X-ray there. And again. Yeah, so we're going to go into the head at this point in time. That should be fine. It's in that lateral aspect of the head. Now, I could always translate a little bit more if I wanted to, but so now we'll go ahead and advance.
So you've got both those options, Peter, have you? Just to pause for a second. So if you haven't gone as far as you might with your displacement of the head, you can adjust that, or you can opt to adjust the jig or swap out the jig depending on where the wire's sitting. You've got both those ways of adjusting. Is that right?
Correct, correct. You can adjust medial lateral with the just with the insert, just with the aiming section of the jig. Correct.
Right.
All right. So now I'm feeling I'm going to hit that second cortex. We talked about the importance of that, right? And so we can see that second cortex there. And it's a good cortex. Yeah, it's good bone here.
Whilst Peter's driving that in, I think this is something you brought up, that once you see the wire going through that second cortex and into the head, what is it you said to me a minute ago that it makes you think?
When you drive that wire where Pete has it placed, you know that that's a home run and you're heading home. It's very comforting, and you're turning a corner, and basically you know you just have another single wire to fire, but this is the home run wire and the home run screw.
X-ray.
Yeah, we'd call that a goal rather than a home run. But I agree, that is what makes you walk away from the case and go, that's going to work. And that will be exactly where I left it 6 weeks later when they come back and they have an X-ray. So this is why it's so important. I'm stressing the point that Peter's taking his time, but he hasn't got any beads of sweat on his forehead. The jig is doing all the work of holding everything still.
All right, now
back to you, Peter.
Make this second incision, and we'll place our second wire.
Well, that looks lovely.
We'll check something here in a second. But... All right, X-ray there. We'll make sure that's down. On it, good. Okay, we can. And we'll put in our. Now you can use the larger wire if you'd like. You can certainly choose to do that. X-ray there. It's skiving a little bit, so we may have to use the bigger wire for this one. Sometimes with the 3.0 millimeter, it will skive X-ray. Yeah, let's use the bigger wire here. So we'll pull the blue sleeve off and use the bigger wire, because sometimes with any patient, it can skive a little bit.
Which is a technique that I frequently do even in the freehand style. I'll oftentimes use for my distal 101.4 just because I need it to avoid skiving. And then I can just thread easily the 0.9 guide wire in over that.
Becky, I'm with you on that. And I think, the two screws are important because you get rotational control. And with these big shifts, you're putting, there's too much risk of rotational displacement if you don't put the second screw. So we need the second screw, but I, like you, will quite frequently revert to a larger wire just to get the position first. You can exchange it.
Let me move this. Sorry for the delay.
So Peter seems to be making good progress there. Erroll, do you remember me speaking to you about the cortical sandwich?
Yes.
That's what we're aiming for, and that's what we're hoping to see from Peter, is that the 4.0 proximal screw's got the two cortices, and then the distal 3.0 screw isn't picking up a second cortex, but instead is sandwiching those that distal cortex between the two screws, and we'll see that on the image intensifier in a minute.
So you can see where the screws are in the head. If you'll see you can see the wires all the way in the head there. Mm-hmm. So you can be confident in the head's aligned. You can see the goalposts with the first ray. We're aligned there, and we're in good position. So now we can go toward measuring our, you can go ahead and hold it there, measuring our depth. All right, so X-ray there. So we've got
usually
that.
about a
so
52,
that's a good.
That's a great sandwich.
These are old eyes here, old eyes.
Yeah, you've got a perfect sandwich there, Peter.
Perfect sandwich.
Thank you.
Let's go with the 58 if you got it.
It is true. When you see this in the OR, you just feel real good that this patient's going to come back and see you, and the X-rays are going to look just like where you put them.
That is correct.
I mean, I honestly, that's the perfect X-ray for me. I want to see those two screws exactly like that. Peter, you must have done a few of these.
Just a few here and there. I was taught by a really smart guy. Let's go 48. So,
to reiterate, this is just a really good feeling when you get these wires in this position.
All right.
You're incredibly confident, and it's as good a feeling as a well-done MTP fusion or any other case like that where you simply know this is going to be okay. And so that's a great view there, Peter.
So we'll go ahead and drill. Now I just advanced this a little bit so it doesn't catch on the other, doesn't come out. But all right, so we'll hit the second cortex here. Obviously, in a regular person, you'd want to be careful on the skin on the medial side, so just be aware of that. But
so a little technique tip I do for that is before the beginning of the case, I actually take a 4x4 gauze and I just cut out a corner and then put it on like an op site. And I actually just put that gauze on the medial malleolus and it's on there. And it protects the skin, it pads it from my fellows.
I will double wrap a Coban right in that area to protect the medial malleolus.
Oh, where's the guide?
Those
Where's
sound
the
like quite
drill
good,
guide? Or this
good tricks.
Screwdriver, the guide. So the other thing, if you want to do, we've got a sleeve that you can put in here that helps to protect the soft tissues. And so we can put that in, and then the screw goes right over top, or right through that guide, and that allows you to protect the soft tissues as you're putting the screw in. So you'll see me advance the screw. Obviously, while we're doing that, I think one of the advantages, like I said, is it gives you some opportunity to make some adjustments. So if I'm not like that second K-wire wasn't going exactly where I wanted it, traditionally, if let's say that was my first K-wire, I'm struggling to hold the toe at the same time I'm trying to place the wire while I'm trying to hold the position, X-ray there. And this allows me now to take a pause, regroup. I don't have to worry about, oh, I'm going to lose my correction now. I've got the ability to kind of step aside and reevaluate and make any adjustments that I need to make. X-ray.
Yeah, absolutely.
So that's the real nice thing about this is whereas before I was getting cramps in my hand trying to hold the toe at the same time and everything, that this allows me to not have to do that, which again, every procedure has little nuances, X-ray there. And sometimes there are little twists and turns, and you just have to be able to adjust and make the adjustment for those. And this enables you to do it in a much less stress-free manner. So, here we'll do that. Do you want to put a 4
We can't see your face, Peter, but you're making it look very simple.
And so, we'll go ahead and now. Sometimes you can put a 4/0 screw. Sometimes you can put a 3/0 screw. I think either way is reasonable. X-ray there. I'm going to go ahead and put a 4/0
I use a
here.
3/0 most of the time, but if it's a fairly athletic patient and a big shift, and I think there's space, then I will sometimes put a 4 mil in. But most of the time, a 3 mil will suffice. It's really controlling rotation.
And so, but again,
Any
the
other
nice
comments
thing
from the
is
panel on that?
that I'm not having to control rotation while I put this screw in, because the guide itself is controlling that rotation for me, rather than me having to struggle to try to control that at the same time. X-ray there. Good. And so we're going to see
I really am
screws.
impressed with the way you're able to almost deconstruct the process. You're thinking about the different elements. You're not compromising on one element because you're struggling with another. You're able to think about each one of these elements of the surgery in all 3 dimensions in your own time, aren't you, Peter?
Yes, yeah, it does. And that's a good, you oftentimes hear athletes talk about the fact that they, when they get better at things slow down. And so here we are, the screwdriver's a little stuck here, which sometimes happens. But
are you comparing yourself with Keanu Reeves? Are you going in the direction of the Matrix here?
No, but sometimes these things happen. What is?
Take a little mallet.
There we go. Got it. All right. Sometimes that can happen. You just have to back it off a little bit. All right. So now the good news is, so now we have our shift. We have our 2 screws in. I'm comfortable with knowing where they are. We're going to go ahead and take the distal pin out, remove it. We're going to go ahead and then I'm going to take my little cheat wire out, I call it, let me give the other, to take the kind of prevent myself from rotating inferiorly. And then we're going to take one of these out, the most distal wire out, but we're going to leave the proximal wire in for the moment. You'll see why in just a second. I can back it out just a tiny bit. And then we're going to remove the guide so we can, at this point, we loosen it. We can rotate upward, remove it out of here. We can take an X-ray, see where we are. We can see where...
Let's do that, Peter. Let's see your work.
All right, X-ray there. So we can see that there.
Well, that looks really nice.
You can see X-ray there. And again, we can see where we're right down the shaft. I've got that K-wire just a little bit long because I put it there to over-drill it just a tiny bit. But so now this is also this nice guide, which is the spike removal or spike resection tool. So you put the screwdriver hub on, and then you can take this down here. It kind of rotates onto the platform. Now we're going to go ahead and place a K-wire in across through the spike resection guide, and so we'll kind of get it through there. There we go. Let's see here.
I really like this element of the surgery.
Now you do want to kind of hold your hand down against the surface just a little bit while you're doing this, so it doesn't kind of peel off, and so you can just kind of push your hand down just a little bit. That allows you to engage that cortex. And again, this is pretty hard bone, so we'll put that in. Go ahead, X-ray there. It allows us to take that little spot right there. Now we'll take this off, and we'll now use the drill. We'll make a small incision here. Right here. Got it. We'll make a small incision right at this location. And we can take this drill, and this is going to be, in the shaft area. You can then place your drill, your larger drill over top of it. Drill slowly here. I'm just trying to kind of make a hole, basically, for my, there we go. And so we've got that pilot hole now. Pull that out. And now we've got the pilot hole that's kind of lined up for you to go ahead and use to remove this piece of bone. So X-ray there. And now I'm going to kind of angle this way a little bit, and I'll go ahead and go inferior first to kind of make that inferior cut on the spike. And this can be sometimes one of the most frustrating parts of the case. You finally get the osteotomy done, and especially when it was a freehand technique, and when you finally figured out how to do that, and the next thing you know, you're struggling with this. And David, you made a comment earlier about these cuts on the dorsal side, aiming just a little bit kind of dorsal lateral to kind of take that shelf off, and I think that's important. I do that as well. I don't know if you want to comment on that.
Yeah, so it's just sort of beveling that dorsal corner. So the dorsomedial corner is obliquely removed. And that just leads to a more natural, smooth edge on the metatarsal there. And I really like this stage in the surgery because having drilled that hole, that's the hard bit done, as you say. Then you can just think, okay, my plantar cut can be straight and my dorsal cut can be oblique. And your mind's not thinking about holding the burr in the right spot. You're thinking about the angles, the things that really will be fine-tuning and the quality elements of your thought process.
And so now that I've made the cut, there's, you can reach in and grab that fragment. In many cases, I will push it in and just push it into the cortex. And that will oftentimes x-ray there. Kind of pushes that cortex in. You can see, let me go the correct way, x-ray there. You can see now that that just kind of blunts that edge, and now you've got there's your mica. So we're not going to do the, we'll take that wire out here, yeah, just for, but we'll, you can see, so
Peter,
relatively stress-free, much easier than the old days where you're trying to hold your hand this way while at the same time you're trying to fire wire this way. All at the same time you're trying to get AP and lateral views, simultaneously. So this really is an advancement, and I think as we've talked about, going to be a significant game changer and stress reducer for anybody, both the inexperienced as well as the experienced surgeon. To make this a more reproducible and consistent outcome.
Peter, thank you very much. That was a great demonstration. And I'm going to go back to the panel now. I've got a few more questions. So I know both of you have had a chance to use this jig, this guide. Erroll, first, what do you think? What do you think of it? I suppose is what I'm asking. How easy is it to use?
Initially, I had to learn how to use it. With all new toys, you have to learn how to do that. Once you've done that, this thing is a game changer. Pete just did an extraordinary job. One of the really nice features here is that spike remover. Those of us who have done a number of these have encountered, on occasion, a skin burn immediately, or over-resecting that spike and then exposing your screw. This guide prevents that from happening. It also just reduces, as I've said before, your stress significantly, allows for perfect screw placement, tremendous head placement. It's truly an amazing tool.
That's quite a commendation from you, Erroll. Becky, I know you've also used it, and I understand that you're in charge of the Fellows program, aren't you?
I am.
Have your fellows had a chance to use it?
Yes, several of them had an opportunity to use it, and they've also been training with me using the freehand technique. So I think they're in a unique position to compare the techniques using the solo guide with it and going hands-free with an attending who's done plenty of these with them, and they themselves are sold. I mean, just like Erroll had said, it's a game changer for them. They feel like it's something they're so much more comfortable going out into their practice and not having Dr. Cerrato or one of their attendings sitting there, hold this, go to the right and do this. And it's just given them a level of not just confidence, but it just makes the steps of this that much easier. And I think what Pete had mentioned with the hand cramping is real. So if you do enough of these procedures in a day, by the end of the day, my left hand is sore as far as like holding the hallux in that position when you've done 4 or 5 of these. So again, there's just so many reasons that this has become, something that's just easier in this technique, easier for my fellows to do it, and when they're in practice, they're going to do it.
Well, I think that's really powerful, isn't it? The fellows saying that it makes it straightforward. The fellow saying it's game changer. I think that's very, very powerful. So I want to now understand, we've all said that this is something that needs to be taught. This is something that the surgeon approaching this technique needs to be going to a lab and being shown how to use. What's the program? We know Stryker are really committed to education. What's the program in the US? How does it work?
Well, training is paramount. 3 words for you: training, training, training. Pete is a master. He made this look incredibly simple. It still has, there's some things about it that you still have to learn and know how to do, and this jig makes it so much easier. But one still has to learn how to manage the burr, how to protect the soft tissues, and things like that. So in my experience, I did 2 cadaver labs. I did the one with you, David, and then later went back and did another. And then that pushed me forward to doing these. What I think the guide is going to do is reduce that learning curve for those who are using it.
Thank you for that insight, Erroll. And Becky, what is the state of the Stryker program in the US? How does it work?
Yeah, so Stryker is committed to the education of percutaneous techniques in the MICA and the MICA Solo guide, and recognize that in order to successfully implement this into your practice, that you need to be trained on it, and you need every person's going to have a different level of comfort, or how many training labs they may need, or different other ways to learn how to do it. And so they have many opportunities for surgeons to learn how to use this, not only guide, but just percutaneous foot surgery in general. And so, highlighted here is there's at least 3 regional courses that are spread out throughout the country here that offer the surgeons an opportunity to train. There's also multiple different societies will offer MIS training labs. MIFAS offers a annual basics course as well. And then aside from just training courses, Stryker also gives the surgeons opportunities to train in other ways. You can participate at one of the regional locations. So if you want to come to either here in Mahwah or come down to Memphis, you could do a training lab there. You can ask them to come to you. They can actually take one of the mobile labs or RV programs and coordinate that. So surgeons can speak to their local rep and have that coordinated so that they could do the practice at their field. There's MIS field specialists that travel all around this country that will actually help you practice the day before, be there to help you in your first procedure. Virtual reality is now an opportunity for training in this, and Stryker is invested in that. There is a MICA training module that has been created, including adding the Solo guide to this as well. And so surgeons can also use this to get numerous cases, that repetition, get the steps done before they even practice on a cadaver if they want to. And then finally, one of the other things I would recommend is the MIS refresher webinars. And I know all 3 of us have been participating in these. My suggestion would be with that is maybe consider doing that after you've done your first 1 or 2 cases. Because we all know once you've done 1 or 2 procedure, any procedure that's new, you probably come up with more questions after that case than you had going into it. And we invite the surgeons who participate in the webinar to bring the case. We can talk pearls, we can go over indications, and I think people come out even that much more comfortable going forward, in their forefoot and their PROstep practice after that.
Thank you, Becky. And that really is quite a comprehensive program. It really feels like Stryker's got your back if you want to take this up. And I'm pretty excited about the guide. I've been teaching now for 14 years, and it really is, I think, to use the phrase that's been used a lot this evening, a game changer. I really do think so. So I want to thank everybody on the other side of the pond for your participation this evening. It's been a real pleasure. And Pete, you did a great job. That was an A1 MICA correction you did there. So I want to thank everybody listening this evening, and I'm going to wrap it up. I'm going to say good night from London, and good night on behalf of the panel in the US there. So thank you very much.